This is the Public Health Gap, a weekly conversation about the distance between how healthcare systems are designed and how people actually experience health. I am Dr. Bradley Fevrier, public health educator and health promotion consultant. My work focuses on how policy incentives and behavior shapes real-world outcomes long before statistics catch up. Each episode, I examine one structural shift forming beneath the surface. Not just what is changing in healthcare, but why it was almost inevitable. Because most health problems don't start clinically, they start structurally. We still talk about healthcare as if the hospital is the center of medicine. But policy decisions over the past few years suggest something very different. The hospital is slowly becoming a backup plan. Patients are being treated at home. Acute conditions are monitored remotely, and reimbursement models increasingly assume the building is optional. So today, I want to explore a bigger question. What breaks when healthcare loses its physical center? Let's start simple. Hospital at-home programs, on the surface, they sound like a pandemic improvisation, a way to reduce crowding when hospitals were overwhelmed. But this explanation misses the point. The pandemic didn't create this model. It revealed that the model could be reimbursed. And in healthcare, reimbursement determines reality. For decades, care required admission not only because it was clinically necessary, but because the payment system required a facility. If a service could not be billed outside the hospital, it effectively could not exist outside the hospital. Then temporary waivers allowed acute level care to be billed at home. What happened next is the important part. Health systems didn't stop. They built infrastructure, remote monitoring centers, mobile clinician teams, central command dashboards. You don't build permanent infrastructure for temporary problems. You build it when incentives align. Hospitals reduce capacity strain. Insurers reduce costs. Patients avoid exposure of risk. When all three benefit, the model stays. And now the pathway looks different. So instead of we having patients to the emergency departments, admissions to bed, we increasingly see patients, assessments to monitoring to health-based treatment. This is not a convenience change. This is a structural change. Because one treatment no longer requires co-location, the building stops defining care. We often misunderstand healthcare as a clinical system. It is actually a logistics system with clinical expertise inside of it. For over a century, medicine organized itself around proximity. Doctors, nurses, equipments, and patients gathered in the same place. The hospital solved coordination, but digital monitoring solved coordination differently. You don't need everyone in one place if safety can be verified remotely. And that changes what a hospital becomes. Instead of a default location of treatment, it becomes the escalation location of treatment. In other words, the hospital shifts from destination to contingency. A destination is expected. A contingency is avoided. When hospitals become contingencies, operational assumptions change. Length of stay metrics, throughput planning, staff allocation, capacity expansion, patient expectations. People stop asking, which hospital should I go to? And start asking, do I need to go at all? That's a different healthcare psychology. Now, this is where the public health gap really appears. Clinical systems adapt quickly to incentive changes. Public infrastructure adapts slowly. When care moves into the home, responsibility moves with it. So monitoring becomes shared. Recovery becomes supervised by family. Environment becomes a clinical context. But policy hasn't caught up to that reality. We're decentralizing care. without decentralizing support systems. What determines whether home-based care actually works? Housing stability, caregiver availability, internet reliability, health literacy. Those are not medical variables. They are social variables. So the same reform that improves efficiency can widen inequality, inequity if support systems lag behind. Healthcare capacity expands, but only for people whose environment can absorb clinical responsibility. The building once equalized some of that. The home does not. This is actually where I see organizations struggle. Systems adapt operationally faster than adapt behaviorally. Policy changes, workflows update, but expectations don't. And this mismatch is where confusion, non-adherence, and inequality appear. Over the next few years, watch for a subtle clarification shift. We will begin informally categorizing homes by care capabilities, not publicly, but operationally. Some environments will qualify for advanced home treatment. Others will default to facility care. Insurers will design benefits around this. Hospitals will triage based on this. Communities will feel the effects unevenly. You'll also see community paramedicine expand, not as emergency response, but as mobile care infrastructure. Emergency departments will increasingly function as routing hubs rather than admission pipelines. The hospital doesn't disappear, it specializes. Intensive intervention instead of routine recovery. Escalation instead of default. Healthcare change rarely announces itself. It accumulates quietly until the old model stops making sense. Hospital at home is one of those changes. Not dramatic enough to headline, but significant enough to reorganize expectations. If you work in healthcare, education, or community health, and outcomes aren't matching effort, that gap is usually structural, not motivational. I explore one of those shifts each week in the written briefing, and occasionally through applied projects and partnerships. You can find the briefing and related work at the link in the description. Next week, we'll examine another place where design and behavior diverge. Until then, notice what systems are encouraging, not just what they are asking people to do.